Welcome back to Moms on Their Best Behavior, where we view each and every individual as valuable and capable.
The purpose of this podcast is to share helpful information learned from years of experience in special education and behavioral backgrounds that we now apply to our daily lives as moms of young kids.
We hope you enjoy.
Hi, welcome back to Moms on Their Best Behavior. Today we have the absolute pleasure of speaking with Dena Kelly. Dena is an LPC, BCBA, LBS, and is a licensed professional counselor and board-certified behavior analyst, renowned for her over 15-year dedication to improving children's eating, enhancing their quality of life, and positively impacting their families. After over a decade of direct feeding intervention, Dena founded Focused Approach, developing comprehensive feeding programs and training professionals and caregivers in interventions grounded in applied behavioral analysis, or ABA. Today, Dena shares tips for us as far as identifying whether your child maybe just has some more picky eating tendencies versus more of like a medical feeding need. She shares how to get the medical care for feeding and what feeding programs might look like, as well as sharing how to use positive reinforcement to increase all sorts of different types of healthy eating habits. Dena is really such a wealth of knowledge in the field of ABA and just working with different type of feeding issues and skills, and really just shares how both of her backgrounds as an LPC and a BCBA just marry perfectly together in her approach. We loved learning and talking with Dena, and we hope you guys enjoy as well.
All right, welcome to Moms on Their Best Behavior. We're so excited, Dena, to have you on today to talk about feeding. Can you start us off by telling us a little bit about your background and how you ended up in specializing in feeding?
Sure. Well, it's interesting. I landed in feeding completely by accident, actually. I did my graduate program in clinical psychology and preparing to get my LPC. So that was my original background. Plan was to be a therapist for children. I anticipated working with autism in some capacity. And while looking for an internship placement, I landed on an autism clinic that also had a feeding therapy center, and it worked with intensive feeding kids. And that's where I landed for my first part of the internship. And I learned so much during that semester that I knew I was taking a turn in my career path and what I was going to do from that point on. So I ended up staying in that clinic. I grew in that clinic professionally and ended up realizing, how much aid we were utilizing there. And I already had an LPC. So then I went back and got the BCBA so that I was having the official certification for the things that I was doing. And so, it's great at this point for me now. I feel that actually both of those certifications benefit the approach that I use for feeding. It gives me those soft skills to connect with families and understand those family histories. And, that behavior background gives me the science understanding to know what I'm doing for the treatment.
That's awesome. Can you tell us a little bit about how feeding specifically plays into all of that? So what does a feeding treatment look like?
Yeah. So, feeding treatment's going to look very different depending on the child, depending on the age of the child, and depending on the concern of the family that brought that child, into feeding. There's definitely a variety of issues and reasons and concerns as to why a child might come into a feeding therapy program. So, there's really a kind of a difference in presentation. So there's more of, I think some people hear of that ARFID diagnosis. And I look at a lot of kids, even though in the actual DSM diagnosis definition, it can start in infancy and be with a child throughout their life. But for a lot of the kids, I see it as something that develops in those later toddler years into the school years and is more associated with some anxiety and aversion to eating. And that can develop from kiddos that also have some generalized anxiety disorder. It could happen from some sort of a medical trauma or an issue, something like that. Maybe they had choking incident, or they got really sick while they were eating. Something happened along those lines. And then we have more of these pediatric feeding disorder kids where we're having younger kiddos that may just be having abnormal behaviors at mealtimes. They don't want to sit in a high chair. They don't want to be at the table. They're throwing their food around. Maybe they are struggling to transition from a bottle to baby food, or from pureed baby food to regular textured food, or they're struggling to chew and use their oral motor skills effectively. There could definitely be a variety of reasons that might bring a kiddo in, which would definitely impact what that treatment would look like for that child.
Yeah, definitely. So I guess for a parent that maybe is kind of just getting started or starting to have concerns, what would you say are the main differences between maybe just picky eating, like potentially could be somewhat common in toddler years, to more of like a medical issue? How could they kind of start to identify that?
Yeah, absolutely. That's a great question. And that's a question that comes up a lot. A lot of families will reach out, and that's what they'll say, is this something that's just a phase, or is it something more than that, right? So when I think about a picky eater, right, and what's typical for a toddler phase is that you're really looking at a child that's having some pretty set preferences, but yet they're still eating foods within each food group and a decent volume to be able to allow them to continue to function and grow effectively. So it's the child that really loves strawberries and doesn't want to eat very many other fruits right now, right? But they have strawberries, and then they have chicken nuggets and hot dogs and bacon. Maybe they're not eating like the greatest meats, but they have some protein in there. And they have a couple of vegetables, that they're willing to, eat some baby carrots or something along those lines. But they're not necessarily branching out and having anything, fancy beyond what those typical kid type foods would be. But they are able to find something to eat when you go to a restaurant, right? They can order off of the kids' menu. You can still take them to the birthday party and they'll probably eat that piece of pizza while they're there. You're not having the angst when you leave the house that, what if I don't pack enough? My kiddo's not going to have anything to eat. We're going to run into an issue. I have a lot of families that avoid traveling because of the restrictive eating that child has, right? So a picky eater, while limited in, the full variety, they have enough things that they're able to pick stuff up along the way, and there's not that same level of stress. We also see with picky eating that they're not brand, color, texture specific as more of our restrictive eaters are. So, the picky eater might like strawberry yogurt, but you could grab strawberry yogurt from Wegmans. You could grab it from, the hotel you're staying at. It wouldn't matter. You could grab a strawberry yogurt from anywhere and they're going to eat it because it's strawberry yogurt. A kiddo that's going to have more of that restrictive eating and, potentially warrant more of that intervention is that child that is only eating the strawberry yogurt that has the picture of Bluey on the front that you get from, the one specific grocery store.
Yeah.
And if you're out, right, you're in trouble. Like I've had families that have reached out and said, we thought we were good because he was eating this yogurt and we were happy with the yogurt he was getting. Well, they switched it from Bluey to Paw Patrol. And now, even though that's the exact same yogurt, he's now not eating it.
Yeah.
And so, that's another one of those like red flags or things that we would look at as more of a bigger issue. That they're really having some tantrums at dinner, whether they either avoid coming to the table at all or at the table, it's really difficult for them to sit there and eat or to be around other people eating. A picky eater is going to want just the things that they want to eat on their plate, but coming to the table isn't such a big issue. Having other people around them eating foods, even if they're different foods than what they want to be eating, is okay. You're looking at what is the impact on that child and what is the impact on their immediate surrounding caregivers and family to really start to assess what that difference might be. We also see a lot that when kiddos are not getting in a good oral intake during the day, is that it's impacting all of the other things around them. So it could be impacting their sleep. If you're not full at the end of the day, right, it can make it harder to go to sleep or stay asleep. It can also impact behaviors. So I talk a lot about, the idea of hangriness, which I think, everybody knows at some point, right? We've all experienced that in our life. But when we have a child that's not eating well at all, right, they're kind of in a constant state of hangriness. And so it makes them more irritable, quicker to tantrum. I look at a lot of children in ABA clinics, and a lot of the times, a lot of children's programs, treatment protocols will have a behavior reduction plan for tantruming. And when I see that, I will also say, well, what does their diet look like? Or what does their, intake look like? Because a lot of times, if we can work on addressing the food intake, we can also then usually see a correlation and decrease in those tantrum behaviors because they're starting to just feel better throughout the day. We see a lot of constipation with kids, and that's a double-edged sword as you're looking into feeding therapy, because you've got kids that aren't eating well, so they get constipated. But then if you're constipated, you're not comfortable, so then you don't want to eat. And so, that's one of those situations where I definitely recommend with a family to first consult with GI so that we could clear out the constipation and kind of be able to start like fresh on a clean slate before we start introducing foods, because you don't want to be eating if you're not comfortable. But those are a lot of the concerns that we see, especially with children with autism, that they're presenting with all of those things, and a lot of them come rooted back to eating. And the last point I want to make, I know you guys have a lot of questions, but on this point is the weight issue. So I have a lot of families that have been struggling with severe restrictive eating, but for some unknown reason, the child is continuing to grow in height and weight. And so even though they go to their pediatricians and they'll say, like, we're really struggling. Like, Johnny is only eating 2 pieces of cheese throughout the day, and we're barely getting anything else in him. But yet somehow every time they go to the doctor, he's 2 inches taller and 5 pounds heavier. And it's just some odd anomaly that seems to happen sometimes. But what will happen is then pediatricians will continue to write it off and say, don't stress, don't worry, as long as they're growing, they're going to be fine. But I see a lot of families that it's still impacting that child's behavior. But a lot of times if that child has autism, that pediatrician will also attribute a lot of those behaviors just to autism. And it's also significantly impacting that family's stress level, which then in turn impacts the child as well. And so weight gain, and it will actually say it in the DSM for the RFID diagnosis, weight gain is not a direct indicator of whether or not there's a problem. Now, certainly if there's no weight gain or weight loss, that can certainly be a red flag for an issue. Growing height and weight and staying on the same track does not automatically mean then there's not a concern. So don't use weight as the only criteria to look at.
Yeah, that's really good to know. Can you go back and talk about the diagnosis you just mentioned and kind of just explain that for people who maybe have never heard of it?
Sure, absolutely. So the one that's in the DSM-5, which is the diagnostic manual, is called, it's shortened to RFID. So it stands for Avoidant and Restrictive Food Intake Disorder.
Okay.
And it is a disorder usually found in infancy and childhood. And like I said, it's one of these diagnoses that usually presents because there is some aversion to food, some anxiety that comes around eating and mealtime and food. And the kids actually appear almost afraid of that food. And so because of that, right, then they are ultimately avoiding eating, and it's causing all of that stress and concern that families are having. So it can be, you're looking for either that significant weight loss, right? You could have nutritional deficiency. You can be dependent on whether it be a tube feed or even a supplement. So when I have families that say, we have a child and he's doing well nutritionally and he's growing, but his primary intake is something like Pediasure, that's not usually meant to be a forever solution. While Pediasure can be used well, right, in certain situations, right? We have maybe when a child is really sick for a period of time and they, just need a little extra oomph, and that's something that they would drink. Or in the short term, between recognizing that there is a feeding concern and actually getting feeding help, Pediasure could be able to provide some of those nutrients, and calories, and be able to get some of that in for that child in the short term. But it really is not meant to be a forever lasting intervention. And so, when we have families where the child is completely dependent on that's an area of concern as well. And that happens a lot with the ARFID kiddos because it is something that's easy. It doesn't have a strong flavor or taste to it. And it's something that kids can become quickly dependent on. But the biggest component of the diagnostic criteria that we look at for ARFID is that marked interference with psychosocial functioning. And that is really the part that I look at from a diagnostician standpoint of looking at how is this food refusal impacting the child's life and the life of the people around them. And that is really the biggest thing that I'm going to look at. Even if that child is doing decently from a weight and nutrition standpoint, if that child's behaviors are impacted, if they're having, we have kids that have to eat in the nurse's office at school because going to the lunchroom is too overwhelming for them. Yeah. We have kids that won't go out to eat at a restaurant. They don't want to go to a family dinner, right? So that food restriction that they have that's really, supposed to be just for themselves is really impacting them from being able to experience all of these other types of events and activities that a lot of them really do want to be a part of, struggle because of that food piece.
Yeah. Do you see a lot of comorbidity between that diagnosis and other diagnoses? I know you've mentioned autism several times, so I'm assuming that's one, but are there any others?
Yes, autism is definitely one. Autism is a big one. And, when we think about those characteristics of autism, when we think about things like rigidity, right, and need for sameness and routine and sensitivities to certain textures and smells and feelings on their hands and that sorts of things, you can see why it can be really easy to develop some feeding challenges with those types of characteristics, right? Because food is a sensory experience, right?
Yeah.
Every food is a different texture, a different color, a different smell. Foods present differently if they are cold or if they are hot, right? Yeah. Or if they're fresh or if they're, right? Like there's constantly those changes. And then things like we were talking about, just inconsistencies as far as brands, right? Brands will change their colors, brands will change their packaging, and that can have serious impacts for a child that is, extremely, set in their routines and expectations of what they're looking at. I had, a child recently who loved drinking apple juice from an apple juice box, right? And they changed from a clear straw to a red straw. And that child will no longer drink that apple from the same exact box and the same thing, but they were now refusing the juice box because the straw was different, right? And so it can be something as simple as that can have the ramification then of knocking out another food or drink of something that they were eating. So autism's definitely a big one. But sure, I mean, I definitely, in my practice, I see a lot of kids that also might have an ADHD diagnosis.
Okay.
Anxiety is another big one. Typically if you're having more of a generalized anxiety, it certainly can manifest itself within mealtime. So I would say those are probably the big three that are, but I also see a lot of kids that aren't diagnosed with any other mental health type of diagnosis and really are just struggling with the food component. Sometimes that's happening, naturally on its own. And like I said, sometimes it happens from a sort of trauma type of issue.
Okay. Yeah.
I've had kiddos that have actually had a very scary choking incident, which then led them not to want to eat anymore. I've had children that, coincidentally after eating dinner one night, happened to get the stomach bug that evening, right? And I think we've all had that experience where, like, whatever the last
you're like, I'm never touching that again.
We have the stomach bug. You don't want to eat it for a really long time, right? That definitely happens. But sometimes what happens with these kiddos is that they have that vomiting experience, and now they just associate eating in general with the vomiting and want to cut out all of that to begin with, so it really can depend. It can come out in a variety of different ways.
Yeah, definitely. Yeah. And I feel like I've seen very similar things, and it's just so hard on the entire family. So I guess if a family or parents got to the point where they really felt like their child needed that medical intervention, what steps should they take? So how do they get to someone like you to get intervention that their child might need?
Yeah. So, I want to be able to say first step is your pediatrician, right? But I've definitely had families that end up self-reporting to me that, by the time they ended up giving up on the medical side and just starting, to search for themselves and ultimately find things on their own because the pediatrician might not have been listening. But I would always start with the pediatrician, advocating for yourself as parents to be able to say, even if you don't think there's an issue, I'm concerned that there's an issue. And do you have any resources or references, of things that I can call and reach out to? But you usually can also type in feeding therapy and your city or zip code, and there should be different programs, and there will be a variety of different programs and different types of approaches to how you look at feeding, and that's going to be really dependent then on what the family is looking for and those goals. So there's things that are really intensive. There's hospital-based programs where you can actually go into a hospital setting and you're there for a couple months, and you're working with a full multidisciplinary team, and it's really, really intensive, all the way down to, there's certain therapists that you can work with for, 1 hour a week and be addressing some things. So I think it really depends on the severity of the child and how the food refusal that they have is actually impacting their intake, their bodies, their overall functioning that they have, and, the goals for the family and what they're looking to get out of that feeding therapy program.
Awesome. That makes sense. For those intensive treatments, I'm assuming you wouldn't do that unless the child was really losing weight or there was really a concern about their physical health. Is that what you see?
Yes.
Okay.
The really intensive hospital-based programs, I usually recommend for families that have a very medically complex kiddo. Sometimes you might have a child that they're having food refusal, but they're also having a lot of vomiting, and they're having, some issues. It's common for kids to gag, but maybe their gagging is much more intense, or they're, having some risks of choking along the way. And maybe we need to make sure that we're working with, somebody that's professional in swallowing, right? And so some of the times that the benefit of the hospital programs is that you're going to usually have, a feeding person, a speech person, GI doctor, OT might be there as well. There's going to be a variety of different people. And so when you have a kid that might be needing, a lot of eyes for, the same sort of thing at the same time, then that's definitely the way to go. But usually hospital programs they're very time consuming, right? They're usually only in a main city, which is usually not convenient for a lot of people. And they have a really long wait. And so a lot of times, even if I have a family come to me where I think that their overall feeding may need some more, multidisciplinary approach, what I will sometimes do is look at and say, what are some of the smaller skills that we can work on? What are some things we could do, even if we can't work on food directly, what could we work on? Or even if we're not comfortable doing regular texture because we're not sure about their swallowing, let's work on expanding their variety of pureed foods while we're waiting, right?
Okay.
So that they can get more variety and volume of food and be able to get some flavors in. So sometimes, there are things that can be done even if a child needs to be in a hospital program that you can do on a less intensive scale while you're waiting and while you're consulting, with their doctors.
Okay, so you are also a BCBA. So how does behavior, like strategies and principles, how does that play into a feeding program that you're creating for a child? How do those things intermix?
Yeah. Well, one, definitely a lot of reinforcement, right?
Okay.
So we're
Love it.
looking at feeding at the end of the day when we're looking at a child that has more of that behavioral food refusal. So we're taking out a lot more of like the skill deficits and kids that might be struggling with their managing chewing or things like that, and really kids that are just avoiding food or refusing food. Is that we can look at that food refusal similar to how we can look at other behaviors within that child's day. And so I look at how do we have ways in which we can motivate and reinforce them to trying some new foods, to taking new bites of things. How do we teach any other new skill for that child outside of mealtime, and what can we use to be able to help teach those skills in mealtime? A lot of kids that have food refusal and potentially qualify for an RFID diagnosis aren't internally motivated to eat the same way that I will say I am. I was going to say we are. I would imagine, you guys like to eat as well, but I will put that into you, right? As most of us enjoy eating, right? You get this satisfaction from putting food in your mouth and chewing it and swallowing it. It tastes good. You enjoy it. You don't need anybody to be there and give you a high five for taking a bite. You gave yourself a high five by taking that bite, right?
Yeah.
It feels good. I laugh all the time. I could eat a full dinner, say, wow, I am so full. And then somebody brings out a really delicious looking cake, and I'm probably still going to take a bite of that cake, right?
Yeah.
Because I am motivated by food and interested in food. And a lot of kids that develop eating disorders do not have that same internal interest or drive in eating. And so what we have to do, though, is recognize that eating is essential for our growth and for our bodies to function properly, like all of those things we were talking about earlier with sleep and behavior and constipation and all of that, right? We need to have good oral intake. And so because we have to be able to do that, we have to look at how can we give some motivation to them to complete this, in essence, non-preferred task, because it's an essential non-preferred task, right? It's a health and safety non-preferred task. But we know that it's not enjoyable to them. They're not necessarily getting the enjoyment out of eating that we might. And so for those kids, we have to say, like, what is it that you do want, right? So the same way that a kid might not want to pick up their toys, right? We don't expect them to just want to do that on their own. But if we said, if you pick up your toys, we can go play at the park, they're going to go pick up their toys because they want to go play at the park.
Yeah.
Right. And so I use a lot of that same mindset when it comes to feeding. Now, obviously, with feeding, there's other sensitivities and things to take into account. And so we certainly don't take a child that's eating, Pediasure and goldfish and say, here's your steak and broccoli dinner. We're not going to start there, but we do start with how can we, meet them where they're at and continually slowly start to push them out of that comfort zone a little bit and challenge their current routine. So we might take that kid that's eating the goldfish and start with a Cheez-It, right? And then move on to some of those other foods that are similar to that, and then get to cheese, and then get to a cheese sandwich, and then a grilled cheese, and you can start to expand off of that. So you're meeting them where they're at, and you're moving at a pace that they're able to handle while setting the mealtime expectations of we need to eat, right? And we need to be, getting in more food to be able to make sure that our body's functioning. But when you asked about things from a behavior standpoint, when we have, especially with my older kids, I get them included in the process as much as possible. And parents are often fascinated. If I sit with a child with a whole list of foods and I have them sort them into different categories. So I'll say, let's put these foods into I would try that, or I might try that, or I'm not so sure about that. And parents will say, they're going to put all of them in. I'm not so sure about that. And a lot of times they get a good handful of foods in the I would try that category right off the bat. And so, it puts that child in control of making the choices of what they're starting with and how they're doing. And it builds up some of that trust and confidence for them to be able to continue on while, having whatever it might be that they're ultimately working for, right? I've had kids that work for, they ultimately want to earn a new doll, or, I have a child now that's dying to go to the Statue of Liberty.
So cool.
He had a really big goal set for himself of, he had to be able to, eat full meals by that time, right? But like, he's almost there. He's only like a week away and he's going to go to the Statue of Liberty, which I think
awesome.
is so great.
Yeah.
He's just been rocking it and doing such a good job, but he continues to take those little steps, which turn into bigger steps, to ultimately get them to expand that variety of food to be able to help their body function better.
Yeah.
That's awesome.
Okay, I have a question which I've been dying to ask you because I think it applies to like everyone, even kids who maybe don't fall into that diagnostic category. But I've kind of heard both sides of this, and I've had a hard time like figuring out where I land. So, okay, here it is. If you have like a picky eater, typically developing no diagnosis, just a picky eater, is it okay to reinforce trying new foods with some kind of like treat? Like some preferred item?
So I will answer that with it depends. So
Okay.
I really try hard not to have a food reinforcer, especially when you're working on food items.
Okay.
I just don't think it's great. I don't really prefer edibles across the board at all. I really don't think it should be what's used as a reinforcer item. It shouldn't necessarily be food. But in certain cases with certain children, if that is really what they want and that is what they want to work for, then I might be okay with it, depending on the quantity and what it was. I think that's it's a hard one, but I don't like pairing. I don't like it when you're pairing it to say like, have this bad food so you can have this good food.
Okay, and
right?
that's the argument that I've heard too, is automatically makes the other food that they're like supposed to be eating look worse than the preferred food, which they're trying to earn.
Right. And so I don't really like that. I mean, I've had kids that actually have had to work on eating things like birthday cake or Halloween candy or things like that has actually been part of their protocol program because that falls into that social category of like something to learn to eat at a birthday party kind of thing.
Yeah.
And so that they have to do that. And so I don't look at, even with feeding therapy, that you have to only be doing super healthy foods or it has to be, the best foods that are out there. I'm really looking at foods that are going to benefit that child in the long term. But I don't. I really try to avoid take this bite of broccoli and then you can go have an ice cream sandwich. I'd rather it be motivators that are not directly food related.
Okay, that's so helpful. Thank you.
Makes sense. So what are some areas that you feel like parents need the most support when trying to, support their child through maybe learning new foods or expanding their diet, those sorts of things?
I think consistency is a big one. So what I see a lot by the time a family comes to me is they have their laundry list of things that they've tried, right? And so they'll say, we tried to bribe with ice cream. We tried to do this. We tried to send them to their room. We tried to be really kind. We tried to be really mean. We tried to ignore, right? And we kind of like went through this gamut of trying different approaches. But what I see, and I think, we see it kind of across the behavior intervention land in general, is that consistency is the first key. So one is, we have to look at finding something and giving it a good solid shot before, assessing if there needs to be a change to that, intervention or whatever it is that you're doing. So a lot of times there's some inconsistency in what they're trying. also just the general life of being a parent and having a family. Some nights are busier than others. And so sometimes you have more time and effort to give to the fight, and sometimes you don't. And what starts to happen with the kids is that they get inconsistent expectations. So there's times where the broccoli's on their plate and mom sits there and makes me eat it, and we sit at the table for an hour. And there's other times where the broccoli's on my plate, but mom's running around doing a bunch of other things and says, whatever, forget it, it doesn't matter, we have to go to basketball practice or whatever it might be. And I don't always have to eat it. And so that's where I think families struggle, is with finding that consistency. And what I've seen with some of my kids, I've actually had some kids that have never really needed a real treatment intervention. So we've started even just within baseline, but they came to the table, they sat down, they picked the foods that were going to be on their plate. They knew what was there. Mom sat there with them, right? And it started in baseline. We continued in baseline. The child never actually engaged in any sort of refusal behavior. And it started to be all they needed was that consistent routine to know what was coming, to know what was going to be on the plate, who was going to be sitting with them, when were they done with their meal, right? Like all of those things. And now, granted, that's not it for everyone, right? Yeah. Some of them need more of that motivation and the treatment component. But that is a huge part of it, is that, you know, when we have kind of crazy lives, as families do, especially children with autism, but even outside of autism, when we're looking at a lot of that food anxiety, it comes from this feeling of the unknown. The biggest thing that families can do is set that consistency. So, you know, what I tell families, even if they're not in a program or their child might just be like a typical picky eater, is I'll say, like, pick one of the nights in the week where it's like New Food Tuesday or something like that. And then the family knows, like, on Tuesday, everybody's going to try one bite of whatever this new food is going to be. And
that's a really good idea.
Yeah, I like that.
You know, it's only on this day of the week that you're going to have something that's unfamiliar on your plate. The expectation is that we all eat it, right? And then we all can go play a board game afterwards, or you can watch your show, or you can go do something after you've done that. And so you're setting the expectation, you're setting the routine. There's no surprises. You know, you're not trying to do any sort of tricking, sneaking some type of food into something else to try to get your child to eat it. You know, it's all out there and honest in their expectation of mealtime.
That's a really good idea. I like that.
All right. Well, I guess to kind of conclude, if parents could take away one thing from this episode, what would you want it to be?
I would want them to know that they are not alone, and it is really hard if you are struggling with a child with significant food refusal. I think a lot of families look around at other kids and think, man, I wish my kid would eat like that. But I do tell a lot of families to also remember that even if they're watching another child eat something really well, that they don't know if that's maybe the only food that they also eat, and it just happens to be the food that's at the event you're at, right? So we've had children that maybe the only thing that they eat is pizza. But so when they go to the birthday party, they eat pizza really, really well. And so when you're another family that's struggling with a child that's only eating mac and cheese, right, and they're seeing this child eat pizza and their child isn't eating that pizza, is that they're going, oh, like, look at how nicely they're eating that. But what you really don't know is that that's the only thing that child might be eating also. And so just knowing that you're not alone. A lot of families are struggling with food refusal as well, and that it never hurts to reach out and inquire for help. So I think a lot of families get told it's just a picky eating phase, but their mom gut is telling them that something more might be going on. I always recommend reaching out, because worst cases, somebody will tell you, a professional will say, you know, you're doing everything right and just keep going. And, you know, you don't need any direct intervention, or here's some recommendations of things that we could do to help you. So there is help out there. And families should definitely seek out a professional opinion from a feeding therapist if they're having any concerns.
I think that's great advice. Thank you so much for taking the time to come on our podcast and give us so much helpful information. I think this is really helpful, like I said, for not just families who have a particular diagnosis that they're working through, but for all families. Like that question about picky eating applies to almost everyone, and a lot of these suggestions and strategies would do the same. They would really help and impact a lot of families in a positive way. So we really appreciate you taking the time out of your day to do this, and we're so grateful for your insight.
Absolutely. Thank you so much for having me.